Good afternoon, good evening. Thank you so very much for coming. It is such a delight. Number one, it's such a delight to see three-dimensional people, so this makes it a very special occasion. It's also such a delight to be here at the WHA having this conference, and I'm going to tell you guys something really important. I need you to take out your phones or whatever you do to kind of be able to capture this, because this is going to be a moment in history. This is one of the most important events for the rare diseases community that is taking place. You are going to be not just a witness to, you are a participant in making history, because this is going to be our launch of the WHO RDI Collaborative Global Network of Centers of Excellence. And it is such a great opportunity for us to be able to work collaboratively in this environment. And I think 2 years from now, 3 years from now, 5 years from now, you're going to take out this picture and you're going to say, I was there. And as we look at the progress that's being made, you're going to say, and I saw the key people that were putting it together. And you've got some of those right here on this stage. So this is so important. So don't forget it, okay? This is really important. You are a participant, not just a witness, you're a participant in history. So thank you very much. My name is Durhane Wong-Rieger, and I am Chair of Rare Diseases International, and absolutely a privilege to be able to be here and part of this. And we're going to go right directly into our program because we've got a number of key important speakers who are going to open it, and then we're going to have an amazing panel who are actually going to be even greater than the speakers. So we've actually asked our speakers to actually keep their comments shorter because the panel is going to come up, even though this is such a great distinguished panel. And I'm going to introduce the first speaker on this panel, who is actually a really good buddy of mine, Dr. Rüdiger Krech, who I have met a good number of times. We've met at the WHO. And I will tell you, there is not a bigger supporter within the WHO for rare diseases than Rüdiger. He has been the one, you know how it is, right? You can do a lot of advocacy from the outside, but if you don't have people on the inside that are actually able to help advance the agenda, you go nowhere. And I will tell you, our person on the inside, who's been the biggest cheerleader, the biggest supporter, not just of rare diseases, this collaborative global network would not be happening without Dr. Krech. So I'm really delighted to turn it over to you to make some opening comments. And you can speak for as long as you want, despite what Matt says. He's going to be the one to shut you up, not me.
So thank you very much, Durhane, for this very, very kind introduction. And thank you, Matt, Jan, and everybody for inviting me here. Today is really a very historic day because I'm just coming from the election of the Director General of WHO. And Dr. Tedros has been re-elected to WHO, and it was actually a very emotional moment as well, because he was talking about his journey and the way he grew up in Ethiopia as a child of very poor parents, and his younger brother dying of a disease which is preventable, a sort of measles-like disease. And he then just described the journey he made to come to WHO and how lucky he was despite this very harsh family history. So it's in this historic day that we're also celebrating our collaboration, and it is actually very, very timely to celebrate the achievements of RDI, of what you have achieved, you as a community, in these very shaky times. Had we ever thought that we would undergo these many crises that we're in 10 years ago? I would have thought, well, the global diplomacy, the architecture that we have is strong enough to prevent a war in the midst of Europe. A pandemic where we were not able to contain it. And the many, many outbreaks that we in WHO see every year, 200 outbreaks that we're seeing every year. And this one we were not able to contain also because it was politicized. So there's many risks in the world, and in this shaky times with so many risks, there's health crises, there's an environmental crisis, there's a social crisis of hate and mistrust, misinformation. And within all this, people who suffer from rare diseases very often take the biggest burden. They get served least. Very often they don't get care at all. And this is unacceptable if we're talking about universal health coverage. Just because a disease is rare does not mean that you shouldn't be cared for. And if we're serious about universal health coverage, that everyone receives the care he or she needs, and the support to the families who care, if we're serious about this commitment, then we need to put rare diseases first. And that is why we, Durhane, Jan, Flaminia, Matt, we've been working together for now a couple of years. You're in collaboration with WHO. We've endorsed this with a memorandum of understanding. And Dr. Tedros, you remember, was extremely eager to have this collaboration with RDI and EUROIS. So to really also formalize our collaboration, have annual work plans, because we in WHO cannot tolerate that people with rare diseases are cared less for. And that is why I think there's also a lot to celebrate today, not only because we as WHO are on your side, but also you have done so much work in the United Nations. So the resolution that passed a year ago is actually groundbreaking, because it also gives you all the rights to be listened to be visible, to actually implement and endorse the right to health. It's not charity that people are cared for and families are helped. No, it's the right. Health is a human right, and the health of people suffering from rare diseases, they also have this right. And that is what we want together to enforce, that you are not the bidder at the entrance of the door, but you're in the room, you're at the table when it comes to decisions in healthcare systems. So that is the first thing I wanted to say. The second thing I wanted to say is that when it comes to services, it's not just any services, but it is services about accessibility, acceptability, quality of health services for people with rare diseases. So it's all those dimensions that count. So when we are looking at universal health coverage, it's these dimensions that we're addressing. And that is something that we want to foster through this network. We want to make sure that people are diagnosed earlier, and that those medical professionals receive proper counseling, proper advice from those people who do this often, so that it's not my first case and I don't really know what to do with this disease, but that I have a network of experts that are supporting me when it comes then to the care and the identification of therapies and what needs to be done. And in order, therefore, to increase not only the accessibility, but also the quality of that care. Thirdly, I wanted to say that perhaps in this network, we want to look at pooling. So how do we pool certain disease areas so that we get the critical mass together? So and that might be then something that we're going to look in this collaborative network, where we actually create centers or identify centers of true excellence that are dealing with pools of diseases, where we then can have exchanges with, where I could see, like looking, you said in 10 years' time, you're looking back at today and say, who was there? But also let's have a vision of what do we want to see in this network? And I want to see that there's exchange of experts between different centers of excellence around the world, which have pooled certain disease groups and who then are exchanging the knowledge, are getting sponsorships from various parts of the world, and who then, through this, accelerate the quality of the network. I would also hope to see that there's a use of innovative technologies. And that is, we've been on Teams for 2 years now. Teams only came in just before the COVID pandemic hit all of us, just a couple of months before. And what IT colleagues tell me that, within a 3-year, 5-year period, we're going to see a revolution of IT mechanism or IT instruments that potentially can also help us not only in the exchange of e-health and m-health, but also in surgery, in clinical guidance. So we can actually use IT technology to the best if we do it right. So these are just some thoughts I have for this network. I'm, as you can see, absolutely delighted that we will have this network, that we're identifying these centers of excellence who will work together. And as I said before, I'm really humble, but also proud that WHO can be on your side. So thank you very much.
Thank you so very, very much. Now you know why we love him. And he also is so brilliant in terms of not only providing the enthusiasm and the commitment and the context, but also very concrete, ideas in terms of what we need to be doing. So I think it's a huge opportunity, and we can't thank you enough for all of the work that you're doing, and for certainly the commitment of WHO to doing this. So this is great. And we're thrilled to have Dr. Tedros going to re-elect it. This is good. I remember, Jan, remember when we had our first meeting with Dr. Tedros, not your first meeting, but my first meeting, have this great meeting with Dr. Tedros and Dr. Krech there. We get done with it, and the only thing he says, well, we had a great meeting. He says to me at the end of it, he says, how do you get your hair like that? I thought, okay, that's cool. So beyond that, we really are delighted and really look forward to the ongoing engagement and the ongoing commitment, because it is truly a collaboration. And it's certainly something that we could not do at all in the way that we want to without the collaboration of WHO. So that's great. So now I'm going to turn over to Dr. Mary Wong, who's going to talk to us about another area in which we're collaborating with the WHO. Actually, Mary's going to talk to us about a task that when I first saw it as part of our MOU, I said, that's ridiculous. We're not going to be able to do this. And that is actually coming up with what they have wisely gone from saying global definition of rare diseases to what is now called the operational description of rare diseases. And I cannot be, pleased that we're actually going to be able to use that as we're moving forward. So I'll hand this over to Mary, who's I've known for a number of years, actually through her work with as a partner with ERDIC, but also now has joined RDI, and we're just delighted to have your partner. There you go.
Thank you.
Good job.
Okay, thank you for being here. I'm really excited to share this piece of activity results with you. So why are we talking about operational description of rare diseases? Why was this part of the MOU? And it's so fundamental because when we talk to our community, the really first barrier that persons living with rare disease they face is visibility. They tell us they need to be recognized, they need to be visible. And so the very first step towards strengthening healthcare systems is that recognition. And we need that global kind of common language and reference to be able to describe rare diseases, because right now there is none. There's no universally recognized definition of rare diseases. Here on this map, you can see countries where there is a definition based on prevalence or proportion of population, and you can see their gaps. And even if there is a definition in place, they vary. And so we here at RDI with a group of experts, we came together and we said we need to have a common reference. We need to say what is a disease, what is a rare disease, and how do you describe it? What is involved? How do we recognize rare disease and persons living with a rare disease? So we, so I'll go back to that, a group of 18 experts coming from all 6 continents, and we really got to work and over several months and coming up with the operational description of rare diseases. So it has 2 parts, a core definition, which describes what is rare, what is disease, and then a descriptive framework with 3 elements to that to be able to interpret that core definition, the context, and what's the unmet need, why the rare disease community demands that attention. And so a lot of discussion went into that core definition. And so really coming to rare, and we wanted to, we agreeing that we have to recognize persons living with rare disease. This is the fundamental part. And persons living with rare disease face distinct and significant challenges that arise from the frequency of their medical conditions, so the rarity. Long diagnostic journey, inadequate clinical management, and limited access to effective treatments. The burden of rare disease on patients, their carers and families, healthcare system, and society overall merits greater visibility and recognition. And we also discussed a lot what is rare. And we agree it needs to be an epidemiological threshold. It's useful to have one. But we did also recognize variable geographies, different contexts. But we want to move towards a global recognition, a global common language. And on the side of disease, we aligned with the International Classification of Disease based on distinct clinical presentation, the phenotypes, irrespective of etiology and irrespective of clinical severity. And that came to this sentence. A rare disease is a medical condition with a specific pattern of clinical signs, symptoms, and findings that affect fewer than equal to 1 in 2,000 persons living in a WHO-defined region of the world. We wanted to recognize different subtypes of rare disease, as well as being inclusive of undetermined diseases, because some diseases are so rare, they do not yet have a name. And with the current capacity of diagnosis, we could not, they're yet undetermined diseases, and we want to recognize them too. And we wanted to recognize that there are different thresholds, epidemiological thresholds for these subtypes may be more suitable. And so rare diseases include rare genetic diseases, rare cancers, rare infectious diseases, rare poisonings, rare idiopathic diseases, and undetermined conditions. And most rare disease can be described by prevalence, but some rare disease can be better described by incidence. So this is really the fundamental core of rare disease where we're coming to. And so just to tell you more about the descriptive framework, so how do we use that? How do we operationalize that core definition? And so we wanted to highlight really the challenges coming from rarity. And the first part is that all the challenges they're facing indeed are coming from they're rare. So they need to be visible, to be recognized, so that we can start talking about them and coming up with solutions. They're facing challenges in getting the right care pathways, and they're having challenges because there are limited treatments, because there are very few being developed. Secondly, we wanted to highlight the burden of rare diseases. So the burden of rare diseases are on the patients themselves, on the family and caregivers, and impact on health and social care, as well as impact on society. So there's several layers of this. They need to be recognized as well. And finally, we want to have this operational description to be a catalyst for action. We need this common reference, and I wanted to echo words of Dr. Krech on pooling. We need to have the same language to be able to pool those data, pool the expertise, to have interoperability, to be able to talk to each other. And so having this common reference will support capacity building and knowledge sharing. And with that, also strengthening the healthcare system to improve health outcomes for persons living with a rare disease, and also echoing the UN resolution to also confront challenges beyond health and be holistic. So I've been telling you how rare diseases are very rare. I wanted to remind you rare disease is many. Rare is many, because there are over 300 million people living with a rare disease around the globe. So estimated 3 to 7% of population have rare disease. So altogether there are many. So rare is many. Thank you very much.
Thank you very, very much, Mary. And, this can be expanded upon, but hopefully, regardless of where you are in the world, quite frankly, and I'm just delighted to see so many people from around the globe here. This is absolutely, a great opportunity, but also in different contexts. This has really been a brilliant way of parsing the definition. So great, thank you very much. Now I'm going to turn it over to Flaminia Macchia, who is the Executive Director of RDI. Flaminia has been with us, I think, a couple of years now, exactly, and is going to expand a bit more in terms of our work, in terms of the collaboration with WHO, but also on the global network. 5 proposals on global networking to strengthen health systems for persons living with rare diseases. And really, I think this is something that's going to be kind of the core of what else we're going to be talking about. So over to you, Flaminia.
Thank you, Durhane. So as we just heard from Mary, there are specificities, there are specific challenges linked with rarity and linked with complexity. And these challenges, they have a strong impact on the estimated 300 million persons living with a rare disease worldwide, but also, as you said, on their families. So RDI, being the global alliance of this population of persons living with the rare disease and their families, we always start our reflections with their needs. Obviously, these needs would be best addressed as close as possible to home. So ideally, knowledge, accurate diagnosis, clinical expertise, high quality medical and social care would be accessible nearby. But we all know that this is not the case, so why not? What is the problem? Well, a big part of the problem, as we just heard also from Dr. Krech, is that there is no critical mass of patients in each country to develop enough understanding of each of the 6,000 rare diseases to be able to diagnose and organize care for persons living with the rare disease. This is even more crucial in smaller countries, in rural areas, and in lower income countries where resources to build expertise and organize care are particularly scarce. So this is why, and this was really the starting point of the discussion with the WHO, this is why we need a global framework to facilitate access to expertise and diagnosis from anywhere in the world and truly leave no one behind. So all of this underlines the need to strengthen healthcare systems and collaborate at national, regional, and at global levels. So this need to strengthen healthcare systems for rare diseases to advance universal health coverage has been recognized at global level by two key documents, which are the UN Political Declaration on UHC, where there is a specific mention of rare diseases, and since last December, also by the UN resolution on addressing the challenges of persons living with the rare disease and their families. So what we need now, that we have two key documents, is a specific commitment on universal health coverage for rare diseases that recognizes that health coverage is not universal unless and until the needs of persons with rare diseases have been addressed. This is the context in which, together with a panel of experts, 250 experts, RDI has been leading and coordinating a reflection process on the creation of a global network of networks made of experts, of clinics, of expert centers who would collaborate together to gather the knowledge that is existing globally and to develop additional expertise and capacities locally, so to promote quality care, including diagnoses, including therapies and medicines, and essential medicines and diagnostic for rare diseases. So this is an ongoing reflection. Within this panel of experts, with 40 experts, we created a working group on strengthening national healthcare systems, and we developed some proposals. A survey was launched to identify best practices that already exist, and building on that, we co-developed an initial draft of a statement that includes 5 proposed areas of intervention to strengthen healthcare system. So as I said, this is ongoing. We will need a deeper reflection to finalize the statement. I'll get back to the next steps later. So these are the 5 proposed areas of intervention as part of this initial statement on strengthening healthcare systems. So, and I'll go into more details in the next slide, but the first one is obviously raising awareness for rare diseases. This is also part of the work that Mary is leading on this operational description. What are we talking about? The second one is to encourage the development of national measures, so developing national plans and strategies. There is the creation of these networks that will connect at a global level, supporting multidisciplinary care, because whoever knows rare diseases know that we need a multidisciplinary approach to rare diseases. And last, the investment and support that needs to make the whole framework sustainable. So, into raising awareness for rare diseases. So for each of these key areas of intervention, we have also developed supportive actions. So just briefly, in raising awareness, we believe it's important, this panel of experts, we believe it's important to develop an education strategy and develop partnerships, also with media, with international organizations, so to position rare diseases as a national policy priority. To develop national plans and strategies, there is obviously the adoption of a common description for rare diseases, especially in countries where there is no definition. So it is useful, it could be useful to establish a national working group, a national committee with different stakeholders to identify the needs and the emerging strategies. There is also, was mentioned also the need for disaggregated data on rare diseases, because all of this will support the development and the implementation of a national strategy. And all of this is recognized within the UN resolution. In the part about the creation of networks, which is also encouraged within the UN resolution, we need to identify the individual doctors, the individual experts, clinics, expert centers, and connect them using digital technology and develop a referral system within these networks. In the part about supporting multidisciplinary care, and this is also within the UN resolution, there is the promotion of integrated care and the establishment of multidisciplinary teams and promote clinical guidelines. Support the sustainability of expert centers. The support, obviously, we all think about first the financial support, but support can also be administrative, political support, technical support. So all of this is the first of several steps. So I shared with you these initial 5 proposals to strengthen healthcare systems for rare diseases, but we will continue and we will deepen the reflection to make sure that what is being developed is relevant everywhere. We will organize other workshops. We will share the initiatives that will further be identified. And yes, so what we are going to do is that we're going to write what can be like the final statement, and based on that we will develop some tools to make sure that the community is empowered, the community at large, so that the implementation of those proposed actions will be ensured, will be supported. So like we're gonna do like this toolkit that we will hear more about. So these templates that we normally develop as the global organization, they obviously need to be adjusted to different national contexts. And we plan to open like a learning program that can be accessible so that all of this information is put in a format, in a shape that is digestible, that it's usable, and that will really, really empower the community to use. So thank you very much for your attention. We are very hopeful, as all of this is actually happening. This dynamic has started. So it's now that we need to strengthen healthcare system and support universal health coverage for rare diseases. Thank you.
When we say the community, we mean all of you. We're talking about a multi-stakeholder community, the same as we talked about the 40 experts, in the panel. We are counting upon all of you to be part of this journey going forward, and I really can't thank you enough for absolutely all the support you've given so far. Now we're going to come to the star of the show, Matt Johnson. Delighted. Matt has been, as those of you who've been involved in the project know, has been our fearless leader all along. He absolutely started from scratch in developing that first proposal and has worked alongside of all of the experts in terms of crafting that, doing heavy duty consultations. And I think all of you hopefully have participated in those consultations that Matt has been able to bring on, bringing people into the consultations, but also going out to other groups to do the consultations. Matt showed up at one of the consultations we were doing at 3 a.m. I said, you can kind of tape it, and he says, no, I'm going to be there. So, and then of course he invited me to something, so then I had to reciprocate and do something at 3 a.m. for him. It was like, really? But
and you did.
I did, so no, it was brilliant. And so I'm really delighted. I know, Matt, you have kind of refined this and really worked on it, but through all the work in the consultations. So I'm going to turn it over to you to talk us both about what the collaborative golden effort is, but also the process.
Thanks, Durhane. So it's a real pleasure to be here, and as Durhane said, this is a moment in our journey that we'll look back on and remember a milestone in our community's history. So I just wanted to first of all start off by explaining that clinical networks for rare diseases aren't a nice thing to have, a luxury, but they're a basic, essential, and must-have for our community in order to get the care they need. They're born out of necessity because the complexity of disease requires the knowledge not just from our experts, who are all brilliant individually, but they require to draw on more of a network of experts' knowledge, the global knowledge. So individually, many of the experts are here and many are online. Individually, our experts are brilliant, but together they know more. And that's a simple truth. And with more experience, we get better outcomes. What we're seeing is that our community of experts over time have been developing more their personal relationships and drawing on those networks of their friends and colleagues in other countries. These personal networks have started to formalize into clinical networks which are complementing our healthcare systems. And now, a few years on, this model's maturing and we've got proof of concept. And that's given confidence for the political commitment of developing networks to be cemented into the new resolution which we have and the political declaration for UHC. So that's wonderful news. We're seeing a warming up globally of networking for rare diseases. We just need to connect it globally, have a unifier to get the interconnectivity between countries and regions, because for some ultra rare diseases, the global knowledge can be on the other side of the earth. We've been working with the panel of experts, many are online today, and we're very grateful for the support, and some here in person. It's a real privilege to collaborate with all these experts from around the world, clinicians, but experts from lived experience, and see and try and map the needs which we're trying to address, but also to co-design a solution which can connect each of these diverse landscapes, healthcare landscapes around the world, not putting artificial barriers in place because of structure. We have cemented the work which we've done with the panel of experts into 3 documents: a population needs assessment, which looks at a regional level and a global level, a concept model, which I'll present a bit of in a minute, and an operational framework, which strives to say, we can do this. This is feasible. Let's do this in a stepwise approach and let's progress. I have to acknowledge, and I know Durhane did, the wonderful support from the WHO, the leadership and guidance, which really, without it, I think, you need a friend like that, and we're very lucky. So thank you for Rüdiger and the WHO support, but thank you to all the panel who've been supporting us over the last couple of years. So if we can just imagine a world where a person living with a rare disease, no matter where they live, can access the expert they need who can give the advice for a timely diagnosis, to access quality care through a network of networks, centres in Cairo connecting across North Africa, connecting with in the European region, with Southeast Asia. We want to build this network from a global perspective, as Rüdiger highlighted. It's about pooling expertise, accessing that specialist advice from those experts, because together they know more. They might have seen that rare presentation which their colleagues haven't seen, and really build the global knowledge and build a learning system. We want to leverage the technology advancements, and we want to inform public health policy globally. But working together to inform that, we can use the regional and national structures to implement. So we want to set up the global network. We're envisaging something called regional and global hubs. We still need to do a deeper reflection on what they look like, how centres within each country can come together and connect. But the regional hubs, what we're looking at are virtual networks of patient organisations and clinicians working in partnership, based on shared experience, shared culture, and coming together and having a shared vision. We want to support. Many of the communities have a desire to collaborate, but they need the technical support and digital capacities to do that. So we want to be able to provide that. We want to draw on what we already know. And after a couple of years of the recent pandemic, you know, we've all become a bit more digitally savvy. We want to have national centres connecting in national networks and having a coordinating hub, which that national system can connect with their clinicians locally, primary care services in many cases, because you know that is the common denominator in most countries, but be able to be like a knowledge adapter to plug in to the global knowledge, draw on that, and strengthen the healthcare systems locally. The framework for collaboration, which we see, is very much based on a network care model. Before, care was provided in a multidisciplinary team in one hospital. But we need that now care is informed by a network of clinicians. And so we're centering this on developing and implementing the network care model through pooling, providing advice and knowledge generation. And I think if we're serious about implementing universal health coverage, we have to do it for rare diseases through a networked approach. We want network participants to come forward. We want the innovators, the pioneers, the early adopters who've tried this to come forward and say, try this. We tried that, it didn't work. We want to learn from our existing community. We'll have a steering committee, which for us and for health equity, we want equitable representation from regions around the world and from patients and clinicians for specialties. We're thinking about working groups for centres, the metabolic clinicians coming together, or the geneticists coming together globally under a number of working groups. And we're thinking about clustering that into a matrix approach, one based on common issues like diseases without a diagnosis, where people can come together and find common policies and strategies to tackle that for a group of conditions, or for diseases with a diagnosis, but there's no treatment. And do another approach where we can have panels of experts available to offer virtual consultation through more a clinical specialty approach. These global regional hubs, I highlighted that we need to do a further reflection and under the global network to really test out that model. What works, what doesn't? What works in South Africa? What works in the Indian subcontinent with Sri Lanka and Nepal? We need to learn that before we move to a more deployment phase. So the pilot network, which we're recommending, wants to be stepwise in its approach. And because this is a new way of working, it's a paradigm shift, we want to first of all identify the innovators who are working out of their existing system, because we can't expect systems just to change. Systems like to self-preserve. So we need to identify these innovators. Some are here today, some are online. We need to connect them together to bring them under one name, under one unifying approach, and call them the global network. And from this approach, we can build the pilot network. We can give them resources and support. We can give them space to experiment. We can recognize what works, what doesn't, and illuminate and share with the existing system and say, hey guys, this is working, come over. And we move to a transition, we do a deployment phase where we see the build-up of this model of global and regional hubs appearing around the world. We're not going to do that tomorrow. It will take time, but we want to do it in a stepwise approach. The resource and sustainability of the network, which everyone's interested in, needs to have a balanced funding model where we recognize voluntary contributions of the network participants, because anything global in terms of policy needs to be voluntary, but also maybe set up a global fund and explore what a global fund for rare diseases could look like, explore future partnerships with other agencies around. We have still lots of outstanding questions. We haven't got all the answers. We need to look at how virtual consultation should work, whether it can only be within a region or whether it can be between regions. We need to see what the technical capacities of a platform should be and how will we fund that and sustain it. We need to also see what capacities are needed for our community to take part in these pilots and maintain engagement and maintain this network to be rooted in the needs of the community. We also need to talk about data. We've got our colleagues from Orphanet here, so we love the data, but we need to know how to share it, how to store it, how to protect it, how to use it. And also what existing partners which we should be engaging with, Orphanet, RDI. You know, our global landscape in rare diseases has been maturing over the last 10 years. And this network is a central piece in that new architecture. So we've got a working timeline. We've done initiation of the program. We're looking towards doing a pilot in the future. And then we look to deployment. We want to have the network mobilized with a good representation in time for 2030 to meet the Sustainable Development Goals. Thank you.
Matt, that was absolutely concise, comprehensive, and brilliantly phrased. So thank you very, very much. Yeah, it really, I mean, it's a bit overwhelming if it's the first time, seeing it. I've heard it, I don't know how many times, and it's always inspiring. It's always overwhelming. But I think as we've seen, there's a stepwise approach to it. And it's something, again, that many of you hopefully will see how you can fit into it and help in terms of advancing it. So thank you again so much. I mean, he put in there what has been absolutely a mountain of work. So we know that, and the many drafts and the many iterations of it and the many, many consultations. So thank you again very much for presenting that to us and giving us that bit of a roadmap in terms of where we're going. And I can guarantee you, we're going to do it. So there's no doubt about that. And now, one of the reasons we're going to do it is actually in our next speaker. I'm really pleased to introduce actually a fellow Canadian, Dr. Louise Clement, though we never see each other except internationally. So I don't know how this actually works in real life, but really happy to have her talking about the engagement and community readiness. Dr. Clement is no stranger in terms of these networkings, has been certainly key in terms of the ERN. So those of you who have been involved in that know very much the work that her organization has done. She's Executive Director, Clinical Partnerships and Education Accreditation at the Health Standards Organization. So I'm going to turn it over to you to really talk to us how we're going to actually make sure that we keep people engaged and move Matt's vision forward.
Okay, thank you, Durhane. It's always, she's right. We live in Canada, which is a big country, and here we are in Geneva. But we're not that far away when we live in Canada. But anyways, that's what life's all about. And well, 2 years of COVID has also demonstrated that we all stayed a bit at home and worked through Zoom. So my first reaction to this today is just to tell people how humbled I am and very grateful to have worked with the RDI team in the last 2 years. Jan, I remember discussions that we had together 3 years ago and invited me back to work with RDI. And so it's been a great experience, and I want to thank the RDI team and Matt, my partner in crime, with all the work we've done together in the last 2 years. And so I'm going to finish off the discussion with the RDI team today and really talk about, I believe, equitable engagement and community preparedness. It was really interesting when Matt said, would you like to come to Geneva? And would you like to speak with your heart and your mind? And I said, oh, sure. And then he says, well, what's the title? And so I think the learnings from COVID has really demonstrated the importance of engagement and principles of equity. COVID has allowed us to learn quite a bit actually about our healthcare system and recognizing that there are health disparities. They were there before. I do think COVID has brought us to the surface that, especially for vulnerable populations, including people with rare disease, the elderly, our health systems still need a bit of work to be equitable. And so this whole presentation I'd like to give to you is about this engagement and being equitable and having the voice of all, and to ask ourselves the question, well, is the community actually prepared to be engaged in the development of this global collaboration, global rare disease network? And so I've always thought it really important when we start these big projects to identify some guiding principles. And as we were discussing with the panel of experts and our brainstorming sessions, we said, this is all about shared experiences and a shared culture. And so we said, why don't we write some guiding principles to guide us? They're always easy to come back to when we're going off track. And so these are the guiding principles that we have identified, and we come back to them regularly, whether after workshops, before workshops, and we start to doing, like Durhane says, draft 1, draft 2, draft 3. We come back to these guiding principles because we think they're important to guide our work. As I mentioned, health equity is definitely top on our list. And it's really important that when we're having those discussions, we recognize that disparities do exist, and we open our minds and be aware of those disparities and try to bring in equity, diversity, and inclusiveness in everything we do. From my clinical background, I come from, I guess, when I was trained a long time ago, as you can see with the gray hair. That's COVID news, by the way. When people-centered care, to me, became extremely important in the last 15 years of the work I've been doing. I was trained as a physician, and I was trained to be, you're going to tell the patient what to do. It doesn't work that way. And we really have to bring in this importance of people-centered care and really understanding needs, having conversations with and not for. And in the last 2 years, I would add, when we talk about people-centered care, it's not only about those that are receiving the care. I think we have to be very cognizant of people that provide care. And we know burnout is a situation that brings healthcare that exists through our community of healthcare providers. So when we talk now about people-centered care, it's really about understanding and caring for people, and caring in the sense of the word, and not just medical care. The third principle is about engagement, and it has to be meaningful, and that's tough. We've learned from people-centered care principles that we can get into tokenism. That does not work, and it's not good. And so we always have to reflect on that and make sure that we're meaningful and we're building trustful relationships with people. And lastly, I've fallen into patient safety and quality improvement in my journey as a profession. And when we want to do this, like Matt has mentioned as well, it's really a stepwise approach. And I really believe quality improvement and implementation science really guides our way in how to. And so it's not linear, it's agile. Sometimes we think we're doing right and we hit a wall and we go, oh, this is not working. We've got to go back. And the second principle that's also important in quality improvement is the philosophy of a measurement-based practice and the ability to evaluate ourselves and to ask ourselves, are we doing the right thing? And if we're not, it's okay, we're going to learn. And so this all brings in the importance of learning health systems. So those are our 4 guiding principles. And I'm a big fan of arrows to close the loop. So when Matt built this slide for me, I said, don't forget to close the loop, Matt. I need an arrow to finish up, to come back to the 4 guiding principles. So this is just to reiterate, Matt's spoken about it, Flaminia as well, the importance of the voice of all. And so the work we've been doing in the last 2 years has always been to come out and have conversations with panel of experts. And so we've been working on some global workshops. There's been 4 rounds of global workshops related to providing what could this model look like, this collaborative network. And then we went into rounds of more regional workshops. And the reason we did that was we heard from people that it would be easier to have conversations with similar supporting language, so in people's language, and reflecting their culture and their ways of doing in the different parts of the world. And so, like Durhane said, that involved a couple of meetings that we had to have in the middle of the night, depending on where we were. It's funny though, I'm looking at the gang from Australia and it always seemed to be like, okay for you guys. But we had to find, it was fun, and that's part of having the voice of all. And so I'll present to you what we called our consultation workbook. And the reason we built this was to really create a safe environment for all to have those conversations. It's about dialogue. It's about being able to speak our minds, and whatever people say, there's no right and there's no wrong. And so we created a consultation workbook based on a readiness assessment tool that we built to be able to bring this collective impact and bring these learnings from all of us. And so the consultation workbook is based on what we call the readiness appraisal tool. Very simple. We had to keep it simple. We had to use common language, and it's built really on 5 domains. It looks at equity engagement, universal health coverage, data collection, sustainability, and quality improvement. These are all words we've heard as well from the other panels earlier. And the idea was to create 5 general questions to be able to start that conversation. And we built a few learning resources with it. And so through that, we built what we called our consultation workbook and the discussion guide, because a lot of this is very important. It's about the facilitation of how you do this type of work. So we had to do it. We did 6 workshops, I believe, Flaminia, 6 or 7. And we tried it. We trialed it. It was testing. We were very surprised it actually worked. Whether we had 7 people on the call, whether we had 30 people on the call, it actually did create a means of starting a conversation, which isn't always very easy to do, and really getting some very important reflections from the people. And so these are what we heard. The key message is to value all ways. And we've heard this actually quite a bit in the last, today in these presentations, the word all, A-L-L, it's such a simple word, but it means so much because it's really about talking with everyone and valuing all ways. And so the 4 things we heard was the importance of the community. And the community is not just the people living with rare disease, but the community where they live. And so we have to broaden this perspective of what is defined by a community. As well, we heard very often that even in countries, Canada is one of the issues as well, and Durhane can talk to that as well, but even in smaller countries, the idea of accessibility if you live in an urban area and accessibility to care if you're in a rural area, it's very different. And so it is unequal. And the other thing we heard very much, and this was a true learning for me, is community leaders are extremely important and they need to be considered champions in how we bring the community engaged in this conversation. The second thing we learned was about stigma, and actually a bit more than stigma, but stigma is a reality related to persons living with rare disease. Invisibility, we mentioned that earlier. Mary talked about being visible in operational definition. So the invisibility was also loud and clear from the experiences of people with rare disease, and challenging us all on our unconscious bias. And so when we come back to stigma, when we come back to invisibility, unconscious bias, and I think of discussions that in Australia, New Zealand, discussions we're having as well back in Canada on Indigenous peoples and truth and reconciliation. One of the important things that we all have to come back to is really the embedding the cultural safety and cultural competencies in our actions. And so that's just, another step a bit deeper, lots of learning from our Indigenous communities to address cultural safety and cultural competency. The third one is about population health. And again, addressing rare diseases, people living with rare disease, also through the lens of population health. So we mentioned the importance of awareness and education programs. We've talked about, screening programs that are often built through public health programs. The importance of integration and continuity, and I can't emphasize that. It's so important. Yes, on the diagnosis, yes, on the treatments, but there's also rehabilitation. There's also integration into the community. And realistically, we have to recognize there's also palliative care. So that's the continuum of care that we need to address when we're dealing with caring for people with rare disease. And lastly, the measurement. I'm a huge fan of measurement. I'm a huge fan of what we call PREMs and PROMs, which are patient-reported experience measures, patient-reported outcome measures. This is new. It's been around for maybe 5 or 10 years. It's very complicated because it's going to be a shift in how we measure and what we measure. But the measurement-based practices are extremely important. And lastly, I just wanted to mention, it's been mentioned before, health and information technologies, and how this can be absolutely an enabler in what we want to do. Also recognizing though sometimes regrettably, it can be a barrier. So again, like this unconscious bias of saying, oh, digital and health information technologies will solve everything. Again, from COVID, we've learned it's been helpful, but it's also had its negative impact as well. And so to summarize the comments from the panel this evening, I just wanted to have a last slide talking about informing action through really a connection culture. And so we've heard about healthcare systems, we've heard about healthcare networks, and they have to be based on principles of learning systems, the importance of clinical leadership, but at the same time, the policymakers need to be at the table, the people with lived experience need to be at the table. And if we really want to even go and expand and think out of the box, why do we not have the education system involved in all this? And so the network, it will take time. We need to be focused. We need to be disciplined. And we just always have to start questioning whatever we do. We have to take that time to reflect and ask ourselves, are we doing the right thing? The global network. Again, the pilot should be reflecting the needs of the communities, shaped by communities, and jointly led by communities. We mentioned and spoke about equitable representation, And again, the joint leadership. I've done some projects where we've had co-chairs, clinical leaders, and patient leaders. They're phenomenal. They're just fantastic. They work. And so lastly, to sum up, we were talking about equitable engagement and community readiness. And from the work we've been doing in the last 2 years, we can truly say from our heart that the communities are ready. They want to be engaged. A lot of you are here today, and we thank you. And it's optimizing, it's all about the learning by doing. Value the experience of people that provide you differences of opinion. We sometimes don't like being told, but because it's not how we think, but at the end of the day, it just makes us grow and makes us better. And lastly, this is a quote actually that came from a grandmother last week in work I was doing on youth hubs in Canada. And the grandmother spoke to us and she said, be mindful in building trusting relationships and things will go well. And so I told her, oh, I'm going to take your quote and bring this to Geneva and end my talk with that. So thank you very much.
Okay, now we're going to come into our second panel. Just really, really delighted to have in person 5 of the participants, and then we've got one other that's going to be there from a remote. So yeah, we're okay. Really happy to, I think, build on what you've heard as the presentation, but I think this panel is going to give you kind of the proof of the pudding. You know, is this going to work? Is it of value? Is it actually going to be doable? And what are some of the possible kinds of challenges and how we're going to be dealing with. So this is the panel that's actually, I think, as Louise saying, those communities that are actually coming together to do this. Just very quickly, I'll just introduce the panel, and then we're going to actually make some opening remarks. So we have on the end there, Per Joergensen, who is here from the hospital system in Denmark. We've got Gareth Bainham, who I think was mentioned previously a little bit, but really delighted to have him here from Australia and wide awake, I think, at this time. I'm not sure why. We also have Dr. Carmencita Padilla, who's here from the Philippines and one of the most I think, engaged physicians in Southeast Asian region. We've got next to her Mr. Salman Saif, who is going to be providing somewhat of a patient perspective, but also a real innovative way in which we're connecting. And then at the very end, we've got Lisa Sarfaty, who many of you will know has been a long-term member of RDI, and we're delighted to have her here on the panel. And then by remote, we're going to have Professor Johnny Malongo, who's going to be talking to us about the experiences in South Africa. So in order to get right into it, I think, we're going to hear from the perspectives of the different panelists. I'm going to actually start with, I think, with you, Salman. I think you're up first, right? And what we'd like to know is, given what has been presented here, and obviously you've heard it before, from your perspective, right? How is this clinical network? Is having a clinical network going to be helpful to you in terms of what you're advancing in terms of persons living with rare diseases, and maybe kind of be able to connect that for us? What are you doing, and how does this fit in?
Oh, sure. Thank you very much. So I would say, like 3 things, right? So first, when we talked about developing countries, right? So for most, it's already a challenge to do the basic things or access to basic things like education or health and others, right? And then second is that if you have a rare disease, then just, like complexify the things by 100 times. Third is that the public health care is not that effective, so people needs to go to private care, which is very expensive. That ultimately means that you are left behind, and in that way, for a disease which could be very well manageable or treatable, right? But then also for those who could afford to pay, for them also, like how it works, that the expertise are limited to different centers. So that means still quite some difficulties to travel and access and all that. So what I'm trying to say is that if there is a way to bring those expertise closer, which can help in terms of timely diagnose, and also making or helping with a treatment plan, that can already be a significant value, right? And the good thing is that it's possible to do that, right? Because we as CureforU have done a successful proof of concept starting from Pakistan and then extended to Afghanistan with some European countries to, like make this kind of a pool who can help to bring those kind of expertise where it's required, right? With the guiding principles, and I was very happy to see the slides, which is like equitable representation, joint ownership. So it has to be working together, not one person telling the others to do. And third is that it has to be fit for purpose, which also means that there has to be a learning from both sides as well. So I was very happy to hear what Matt was presenting and others were saying that, because it's all going into the direction with our successful proof of concept. So to your question, it's very much required and it's very much helpful.
I think Matt said it because people like you have been telling him that. That was not something Matt invented. So thank you very much for your examples, for the work you've been doing on the ground. And so obviously kudos to Matt and Louise for being able to pick that up and incorporate it. So great on you. And I think you're going to hear a bit more. So Carmencita Padilla, I'm going to turn it over to you. And maybe you can tell us a little bit, as a healthcare professional, certainly in a very challenging environment already in terms of the Philippines. She's not going to have the opportunity to tell us all the things she's been doing there over the last number of years and the huge advances they've made. But I'm going to ask you a different question, and that is, you've been making huge advances as a clinician, in terms of trying to advance rare diseases and certainly having a huge amount of progress. Is this actually going to make more work for you and for other clinicians in the region who are already, I think, working flat out in terms of being able to address not only the needs of your population, but also being able to spread the work that you're doing?
Thank you. Let me start by saying that I come from a country with 7,000 islands. 20 or 30 years ago, 30 to 40 years ago, they told me it was impossible to implement newborn screening. And I can tell you that 25 years now, we're in 7,400 hospitals in 7,000 islands with a coverage of more than 90%. So I think it's possible, whatever we're doing, but how did we do it? So Matt loves this story, so I'm going to share with you. I said I used a bottoms-up technique, and I shared a dessert in the Philippines. So you'll have to come to the Philippines to taste it. But it's a rice cake that's cooked with fire on top and fire at the bottom. And I said, you have action on top with the leaders, with the policymakers and the funders, and then you've got action at the bottom, working with the clinicians and the patients. So the challenge now for me is that, how am I going to do this with 2 million babies a year? We have an infrastructure. So I think the lesson is for everybody in the community is to start with the infrastructure. I have the infrastructure of newborn screening right now. We've expanded to 29 diseases with a lot of rare diseases. And the infrastructure of the clinicians on the ground is important. There are only 15 geneticists, so definitely this networking is going to be very important for me. I think we're ready, but we need a lot of help. And a push from the global community will even make it easier for us. I work with government, but it's not enough. So if I have this community of clinicians, then it's going to work. So nothing is impossible. I think it is very possible.
You are the living proof of nothing is impossible. And at some point, you need to have Dr. Padilla tell you some of her experiences of actually doing newborn screening with 7,000 islands, especially in the middle of a typhoon. So you want to hear about spectacular nothing is impossible. And now for another view in terms of nothing's impossible, because it is quite incredible. I'm going to ask Per Joergensen to talk about your experience in working with the European reference networks and certainly your hospital, with the commitment of your hospital. But given what you're already doing, why do you feel that you need to be part of this global network? What can you lend to it? And maybe what can you get back from it?
I come from a little country with only a population of 6 million people and a public healthcare sector. The National Board of Health has located 2 different centers for rare diseases in Denmark, and one of the centers is located in the hospital where I work. And it gives us a certain responsibility. We've been very pleased by the ERNs, or European Reference Networks, because we believe that that's the important part. They're good for the patients. They're good for our patients because even though we are used to handle rare patients, we of course also have problems with the very rare patients. And it's very helpful to have access to experts all over Denmark in that regard. And we're also pleased to be able sometimes to help the other European countries when they have very rare patients. I think it's very important for the hospital to be part of this because it gives us an access to an international network of European experts at least, and it gives us opportunities to be on our toes and also to have new research possibilities. That's important for us also in relation to rare diseases. And this formal network, which the European reference networks are, have one big advantage from my point of view, and that is that they have created a system, a virtual system, where we're able to discuss specific patients across borders within the EU. And that's very, very helpful. And I think it is actually very important. In relation to the global network, I think that our hospital might be a sand grain, and the ERNs or the ERN system might be a kind of hub in a national global network. And I think it's true what is said, to pool knowledge is very, very important, and we're very eager to participate. Thank you.
Thank you very much. And what Perry did not say is that out of the 24 European reference networks, their hospital hosts 22 of those. So that's an incredible tour de force. So we're really proud. And now I'm going to turn it over to Gareth, who's going to talk to us about the experiences from down under. And really, I think one of the things, we wanted you to comment on is this operational description. I know you were part of that working group, and how does that work for you there, but also a little bit about how you're actually going about now in terms of the core of centers of excellence, because you're already doing some of that in Australia.
Thanks, Durhane. I think it was possibly Matt that said this is not a nice to have, this is a must have. And we already have. And what I mean we already have is we already have so many people and their families living with rare diseases. We already have an enormous health and social burden and responsibility. We know, at least in developing countries, that rare diseases are the single biggest health system cost. So we already have this great challenge. And that's why it's so critical that we build on the things that we already have in terms of our existing approaches and work with a global network to learn together. A critical step on a patient's journey is getting a diagnosis. So a diagnosis is the portal to best medical care. A critical step on a systems journey is defining what you need to address. Until you define and operationalize what you need to address, you cannot address the challenge. And so I think that's the fundamental reason why this operational definition is so critical for local action and for coordinated global action. In terms of opportunities to learn and lessons to learn from, I think what we're seeing, and certainly what we've experienced locally, is that solutions from more isolated, potentially less resourced countries or regions, and I think even within high-income countries like our own, we can certainly see the great disparities between urban care and rural and remote care. We can see the great disparities between non-Indigenous care and Indigenous care. But amongst those disparities, also we see that necessity is the mother of invention. And we see that those solutions that have been generated and honed in Indigenous populations, or generated and honed in low and middle income settings, or generated and honed in remote settings, are robust and they're generalizable. And so in fact, another advantage, a key advantage of this global network is the learnings that we get in better resourced high-income countries, the solutions we actually get from the global community and how they address challenges in their own contexts.
Thank you very, very much, Gareth. Now we're going to turn over to Lisa. Lisa is here as from the National Organization for Rare Disorders in the USA. And I think NORD, as all of us know, is probably the oldest maybe patient association there is. NORD was instrumental in getting the Orphan Drug Act, without which none of us would actually be here. So that's really important, because without that Orphan Drug Act from NORD, Readiness would not have been able to do what it's doing. So we're all here sort of on the coattails of what NORD has been able to do. But now we're coming back to NORD is actually creating centers of excellence, and actually somewhat late in the game compared to what we're hearing from the Europeans and even from the Australians. So tell us why you felt it was important for NORD to take on this task, and what you're doing and what maybe the vision is.
Hi, everyone. Actually, Hong Kong might have been first. I thought I heard that from someone, that they were founded before NORD. So I'll have to verify that. But so glad to be here with everybody. Taiwan was first. So we don't hold that title. However, back in 2021, NORD launched the Rare Disease Centers of Excellence program in the US. And hearing from fellow panelists, it really felt like an uphill battle that we didn't know that we were ready to climb, to be honest. It's no small feat, but like everyone said here, it seemed there was no choice but to do it. We needed to do it. So patients in the US face astronomical healthcare costs, in addition to lack of access due to a variety of factors having to do with the healthcare system, and just the fact that these diseases are rare, and expertise isn't always in the US or even available nearby. And so what we were finding is that there were multiple clinical networks and research networks and diagnostic networks, but they were siloed and they weren't working together, and patients were still falling through the cracks. And what we really felt we needed in the US was to give patients a medical home, a place that they could go to, geographically located near them, where regardless of the disease that they had the ability to see someone that understood fundamentally what it meant to have a rare disease. So they may not be an expert in your rare disease, but they understand the journey of rare disease. They understand where to go to for information on rare disease. They're connected to other networked clinical professionals and researchers in rare disease. So for me, being part of this conversation, it's taking our vision 100 times further, right? This idea of building out a clinical expert network in the US, and now taking that and extrapolating it globally, and ensuring that patients, again, who have diseases that they could be one of 10 people in the US, but maybe they're one of 100 people worldwide. How do we make sure that they get connected to the expertise and the resources that they need? So NORD took that on as a patient advocacy organization, and I'm glad we did. I was hesitant, I'll be honest, because it seemed more than we could handle. But today we have over 31 centers participating, and we'll probably have nearly 45 by the end of next year. There's over 200 volunteers from across clinical genetics, geneticists, genetic counselors, other specialists working together to really define what this needs to be. So as mentioned, we're really doing it from a grassroots perspective of bringing the clinical community together with the patient community to really define how do we make sure that this supports the clinical community who's in desperate need of resources and support, but then also the patient community, so that their needs really don't get lost sometimes in these bigger picture conversations. Because for individual patients, it counts from the minute they show up at that door. What is their experience showing up to that site? How are they triaged? How are they supported? How long does it take to get another appointment? All of these factors are taken into consideration to ensure a really holistic experience and a baseline for what a rare disease patient can expect. So we're in the beginning, but really looking forward to working with this community to help us as we pilot and grow this program, ensuring that it can support the global community as well as patients in the US.
That's brilliant. Thank you very much. And I think what you're already hearing, I think some of the questions and challenges that come forth, how can you have sort of a concept of a network of centers of excellence when you've got so much variation across countries and across regions? And what you're hearing is that kind of what, Carmen Zita said, you build it from the bottom up and you build it from the top down to fit kind of what the environment is. And I think we're seeing, as Rebecca said to us earlier today, we're seeing lots of different models in terms of, both prototypes of what can be done. So this is exciting. And what Gareth is doing may be a model for elsewhere. We're going to hear from about another model and kind of where the value is in Africa. I think we've got a quick video from Johnny Malungo, who's going to talk to us about what it is like in terms of the possibilities for this kind of network in African services, how it's going to help serve their frontline service providers, but also the patients.
What can we learn from collaborations in the African region? I've learned over the years that there are many dynamic healthcare providers and patients living and working in Africa who are committed to elevating the level of care and delivery in our continent. We've seen this through a number of programs, through the twinning programs of the WFH, through seminars of the ISTH and the American Society of Hematology. And of course, we were particularly fortunate in our center to be able to train a fairly large number of fellows, over 30 in the last decade. And training such fellows actually does not need very high level of resources. Twinning programs and the training programs that we have will certainly make a huge difference as being part of the networking. The second question that perhaps would be relevant is how do we envisage frontline services in South Africa and other countries in the region benefiting from the connectedness of the global network? My impression is that there are actually many benefits that the region could get. I mean, to start with, the network will allow us to build capacity in the region. This is now capacity for advocacy, capacity for diagnostics, capacity for a whole host of other events that we may plan. The networking will also allow us to share experiences in diseases that are actually common in our area. Diseases such as sickle cell, et cetera, et cetera. And the third benefit would be sharing the treatment protocols and the standard operating procedures that we use for the treatment of these diseases. So how do we see the global network facilitating access to universal healthcare in Africa? My impression is that, in fact, rare diseases are unique in the sense that they are sometimes put in the back burner of most health systems, low down the list of priorities. And it is important that when we are tackling rare diseases, we keep in mind two principles. One, the intention is really not to demonstrate the burden of the disease. The intention should ideally be to demonstrate the outcomes following the intervention. And that to me is probably the most important principle that one should follow. And of course, one should take into account the available resources and all of the other factors. And then finally, in my view, what do I hope to achieve with the global network in our community and in our hospital? In short, I'm hoping that the global network in rare diseases will allow us to make diagnosis, to give better treatment for the patients with rare diseases, and to see better outcomes in many of these diseases. That is all I wanted to share with you, and thank you very much, and I wish you well in your deliberations.
So listening to what you heard there from Johnny, how does that relate to what you're doing in terms of building a network in the Philippines? And I also know that you're also been very much networked. You're doing not only a newborn screening, but also with clinical services.
So because of the geography, I have no choice but to do the network within the Philippines. So there are only 15 geneticists. So early on, before COVID, we had to come up with a system wherein we connect with every patient who's positive. So we came up with 15 clinics wherein every patient who's been positive is actually referred to this patient for free. Service is free because it's covered by government. But the beauty about this is that my commitment, our commitment to government, to the Ministry of Health, is that every clinic for newborn screening is a clinic for rare diseases and birth defects. So I'm telling them that if you support rare diseases, you're not really doing another investment. You're building an infrastructure, and they're buying that. So, and I'm thankful that they have just started another roadmap Now, the network that I have is not only for the Philippines, because the Asia Pacific Society for Human Genetics for the past, maybe 20 years now, have come together. Actually, it's a team of geneticists who have been sharing. So I think this sharing is really inside all of us. And in Asia, we just had to do it because we're so few in Asia that we had to start talking to each other. So what we're doing is really going to the next level. It's going to make life a lot easier for the Asia Pacific and the Southeast Asian region. I'm looking forward to working with this group. Thank you.
See that you're not so brilliant, Matt. You've got all the work that's already been done for you. You know, what you need to do is to be able to clone it, to be able to share it, and then be able to bring. No, it's been amazing in terms of getting some of these experience, right, to serve as the models. So I think it comes back to a bit of what Johnny was saying, and a bit certainly in terms of what you were saying, Carmen, and that is, how can this network then help to facilitate the kinds of, developing a platform, sort of a global platform, where we can actually get different systems and different experts to actually network with each other. Matt wrote in here something about a speed dating platform. I refuse to address a question to Gareth and Salman about speed dating, so we're not going to ask him that question. But we do want to ask him the question about how could this kind of a global network, right, actually help in terms of getting experts across very, very geographically distant region and maybe different levels in terms of services and expertise. Is this going to be something that you're going to be able to use? And how does that also address, I think, a question that I think certainly Louise brought strongly, and that is the issues around diversity, equity, and inclusion.
Well, I'm really looking forward to going home and telling my wife that I flew across the world to speed date. But in all seriousness, one of the greatest challenges that this network will help us address, this global network, is how do we match expertise around individuals' patients' needs, around the clinical question that child, adult, and family are bringing to us. How do we in real time aggregate that? And so I think the social dating metaphor, if you like, is how do we match that? How do we do that in real time? How do we match up the existing, the expertise that individual clinicians and experts have, and how do we aggregate that in sort of real time? So I think there's a real opportunity about doing that. I think that's part of the digital health piece, and then will be a number of aspects of the digital health piece that'll be critically enabling, and I think this is a key one. That same mechanism also facilitates a key community need. We're in the middle right now. We're implementing our comprehensive centre for rare care back home at our children's hospital. And when we met with our community reference group for our regular meetings, one of the things that repetitively came up was we want second opinions. We want a way to facilitate that, and it would actually like sometimes, not always, our first doctor involved in the second opinion. And so that same matching process can be used to facilitate that patient need around gathering opinions and second opinions. And it's a way to get scale, because one of the real challenges for clinicians seeing someone with rare disease is identifying who is the experts and who are the real experts. Because there's one thing to have 300 publications after your name, that might denote you as being the real expert, but there are other ways that denote you as being an expert in terms of the good quality clinical care you provide. So how do we create that mechanism?
I think that's a really important point in terms of the clinical care, right? There's so many experts, and I think we heard that earlier today as well, is that let's not forget, there's not just the clinicians and not just the nurses, but there's other allied health professionals. They're all part of that comprehensive care team. And how do you actually make sure that you can bring them all in and maybe even share expertise around those other different levels in terms of, you and I talk a lot about mental health and social well-being there.
Can I just add one thing? I think, and again, it's where a community is leading the way. And if I make a parallel with an Indigenous health initiative, so in our home state, the primary care for Aboriginal Australians is large part provided by Aboriginal healthcare organisations that provide the primary care. And so because of the needs of that community to access care wherever they live, They came up with a solution. They designed the solution, and it was a digital solution using geospatial technology and aggregating data across different health data sets to actually organise care closer to home. So we've seen again another domain in the Indigenous community or a high needs community living in a remote area have created a solution. It's a digital solution that unlocks a human network, and I think that what the global network will allow is the expansion of these and application of these sorts of mechanisms.
And you certainly have been a pioneer in that area. I mean, what you've been able to do in terms of including those marginalized Indigenous and even the remote Indigenous community. I mean, I look at Jennifer here, a fellow Canadian as well, puts us to shame in terms of what we're doing in Canada. We have not done that same level, but this is an opportunity really to borrow from those models. So let me ask you, Salman, based on what you're hearing here, you've done an amazing job of bootstrapping operation in order to provide sort of an expert network, obviously out of your own need, but going way beyond that in terms of other families. But I also understand that you are doing work with beyond your own, disease area, looking at how you can actually expand that kind of expert networking. Is this something that you can see building into this kind of clinical global network? How would you take advantage of it? How might you actually inform it in terms of what else needs to be in place? And not from a structured a clinical environment, but one in which is very much grounded in persons and patients, and also with the clinical experts.
No, absolutely. So I think from the outcome perspective, so for me, there are, let's say, two dimensions. One is that you are actually solving a real case issue, but you are solving in a way that you are training other people so that in future they will solve themselves, right? Because then you have a multiplier, and then you are able to, solve a bigger question in future. So absolutely, when I see that, this kind of this concept of global network, how this can help, and how, when I said that we did a proof of concept, and I want to kind of elaborate on that, it's that there has to be different dimension as well. Like, we don't need to look for a gold standard answer, but more like an operational answer or a fit for purpose, which by that mean is that the both communities in a way, or if you are having a regional networks or across regions, Europe and Asia, they need to work together. Experts needs to work together. There should not be a concept that the experts from Europe are going to tell you how to treat it. You will get a wrong answer, right? So you both need to find an answer which is fit for the purpose. And also the debate on that you were bringing who is expert or not. Actually, we tried a different concept. We are asking young people, what do you think about that case as well? So that you have a senior expert known, but also the young person. And there is a very nice way of collaboration and then interaction, and then how you store all that for the future learning. That's ultimately helping a lot. And then how you use the technology so that it doesn't stay in one country, even in one region, but across region. And to your point, to global network. So that will all feed into that. And I will just close. For me, the key word is integration. Things exist everywhere. It's how you connect them, but not to create, like the work with Joergensen, for example. So their platform, how we can use and then feed it for our purpose. So I think that's the key, how you integrate things together in the end.
We're running out of time, and I realize I've not really left enough time for questions from the audience and others, but I do want to ask this question because I think it really speaks to a different level, and that's back to Per and Lisa. Quite frankly, we're talking about huge needs from the grounds up, and why there might be a sense in terms of experts and clinicians and even the patient community coming and say, yes, we want to be a part of this because it's going to help us. What do you do when you've got already centers of excellence? European reference networks really tried to bring together centers that themselves were saying, we're already experts. What do you want us to do? And also asking some of them to become hubs within a bigger spoke area, hubs and then other spokes. And the same thing I'm going to ask Lisa, you can answer in turn. Your clinical centers of excellence are not just, kind of community networks. They are major Children's Hospital, pediatric centers. And we're saying, we want you to network together. We want you to work together. How do you talk about these people who can set aside their egos to say, sure, there's a value to us in terms of collaboration. So I'll start with there because you've had the longer experience. Then maybe Lisa, you can talk about how you sweet talk these clinical directors into this.
Well, I'll try to do it very briefly because we're short of time. But I think everybody can see the good aspect of more experts. And global experts are better than European experts, which are better than national experts, and so on. But we need something. And I think today is a very important day, as you started out, Durhane. And actually, I think that perhaps the most important supporter for making a national, international network is RDI, because even though we might be very, very keen in the individual systems, we're not able to do it ourselves. We need some organization to have the bigger overview, to provide the infrastructure, and the idea of doing it, for instance, with RDI and WHO, I think is brilliant.
Very much. Lisa?
So it's interesting. There's always a few who don't understand the value that's in it for them. I think that's pretty standard and typical. But in the US, I have to say, we didn't have to do a lot of convincing. And I think part of that is that we had support from Dr. Marshall Summer, who really had been out there socializing the idea for several years to try to get people on board with this idea of forming a network and bringing everyone together. And so by the time we were ready to roll out the criteria process, everyone was already on board and signed up to help us do it. So I think that really helped. I think the other thing too, which I don't know if it's unique to the US, but in the US, you've got centers of excellence for cystic fibrosis, for muscular dystrophy, for pulmonary hypertension. And what we've seen is that, yes, an individual center can recognize themselves and say, we are a center of excellence for this disease. Does it count as much if the patient community doesn't also recognize them as a center of excellence? Not in some cases. And so what we really saw too was this need to really have both parties coming together to say, this is how we define excellence together, and that we are going to validate your designation as a center of excellence in rare diseases by having the patient community stand behind you and support you. And the other thing we haven't talked about that I think is really important is that centers of excellence are great, but it can't stop there, because patients won't always be able to get to a center of excellence. They won't always be able to travel. They won't always be able to get, for whatever reason. So it's really important that as we build this network and we talk about centers of excellence, we're usually talking about.
So thank you very much, and hello to everyone, and thank you for inviting me to share a few thoughts with you at towards the end of this extremely interesting and valuable event. Let me start by repeating something we've said many times, but we still need to continue to repeat. Rare diseases are not rare. The individual diseases are rare, but taken all together, the 6,000 to 8,000 diseases affect perhaps more than 300 million people, certainly maybe even more. To put that into perspective, that's more than half the number of diabetes patients worldwide. So why is this important? Because when resources available to health systems are limited, and unfortunately they all too often are very limited, inevitably that leads to the rationing of healthcare. And the term rare often, unfortunately, ends up deprioritizing patients with rare conditions. So how do we answer this problem, and how do we solve this problem? Well, I think there are 2 points, 2 essential aspects. First of all is the very basic stuff, is really to invest strongly in strengthening health systems. If we're really serious about SDG 3, about universal health coverage, we cannot afford to deprioritize anybody, much less such large numbers of people. And we know that strong health systems are indeed at a rising tide that would lift all boats. So I think the first thing that has been said a moment ago, I think it's really important to emphasize that investing in health systems, especially in aspects of health systems that are very important for patients with rare conditions, is not just will not just benefit patients with rare conditions, it will benefit everybody else. If, for example, there is strong investment in telemedicine, for example, this will certainly help bring care to patients who may be far away from the expertise, but it will also help the management of many other conditions as well. But then we need to also do more than that. That's the basic stuff. We need then to network, and this is what this event is all about. The networking of care, the networking of expertise, and I would say also the networking of patients and the expertise, the first-hand knowledge that they and their families and their carers can bring. This is important. We know that the journey to diagnosis and treatment where available is unfortunately still far too long, and networking is the way to shorten that journey and make it more effective. This is indeed what we've been doing in Europe since 2011 with the European reference networks on the clinical side, where we've really built networks that can bring expertise closer to the patient, irrespective of the physical location of the patient. But we're also applying that, for example, in research, the new European Partnership on Rare Diseases, which will coordinate national, local, and European research and innovation programs to combine research funding, implementation of research support activities, including training, infrastructure to access data, data standards. And this is really important. We are at the moment really at the heart of a technological revolution where we can really process large amounts of data, where research is really giving us more and more answers. And that research will certainly help patients with rare conditions, but will also help everybody else, because hidden in that data will be answers also to other conditions, which may be even more prevalent. So this is really, I think, an opportunity we cannot afford to miss. But again, networking is key, because if the research is being carried out in fragmented oases, not communicating with each other, it will take much longer to find the answers we are all looking for. Now, when it comes to international partnerships, we will apply the same approach. We very much would like to link the European expertise on rare diseases with the global health agenda. I think what really is needed now is to network the networks. It's important to have regional networks, and then it's important to link those globally, so that we can also make the best use of the data that will be available, the expertise that is already out there, and we need more of it, but also to be able to accelerate the research effort, to have better understanding and better treatments. And this is something definitely we are prepared to invest in. I think what we've just heard today is indeed extremely encouraging. I was very much impressed by the very solid work and the excellent progress happening all over the world. I think the time is ripe now to really start to create this global network. Data will be at the heart of that. Data will be the backbone for informed decisions. But of course, data is only good if it is shared. It must be shared among patients, among experts, among centers, the networks. We are already doing that, for example, in some areas, like with rare infectious diseases, our collaboration between the ECDC and the African CDC, for example. But we obviously would like to extend that far more widely to all categories of rare diseases. And I think there's a lot of scope for that as well. And also the practical collaboration on how we can make the best use of that data and how we can also then link that to research. So to conclude, networking is the key. Of course, networking of health systems that are well resourced, that have also the capacity, but ultimately we'll all be able to get much better results from the available capacities if those capacities are networked. And this is where I think Europe can play a strong role. We very much intend to do so. And let me conclude by saying that ultimately the test of any healthcare system is, of course, to provide effective diagnosis and quality of care, but it must do so also in the shortest possible time. Having treatments which are not readily and quickly accessible, of course, is only half the story. The speed is important, and this is where networking really can help, is to help shorten the distance between the patient and the answers that the patient deserves and needs. Thank you very much, and thank you, and congratulations to everyone for the excellent work.
Huge thanks, as always, to Martin for his ongoing support, and certainly the European Commission. Now we're going to close out the programs, altogether fitting in terms of our closing speaker. I mean, we've heard, that it takes a whole community to do this. It's a global community. We've heard all the experts and Louise and Matt and all the consultations been done and the hundreds and maybe thousands of people that participated so far. But if we were to get right down to it, as somebody said earlier, it takes individuals, it takes those kinds of leading lights in order to make it happen. And there is nobody that we are more obliged to that has been more of that visionary and a leading light than the person who's going to close this program. I think we all know who we're talking about. Jan, come.
I don't know if I will be closing. In fact, I think I want more to invite you to open the discussion and to look further. I think when I look at you, I just smile at your eyes, that there is a sense of pride of the journey so far, of where we are. Now, we're all here to create the real change we want to see for the people. So we cannot really be complacent with ourselves, none of us. So what we need to define now is where we go with that. How do we accelerate? Because our duty, what you're doing, our commitments, our values, our vision, our shared vision, take us to move faster and forwards. To do that, we cannot leave it to random or to chance. I think you heard us saying that already in other contexts, in Europe or the US. I'm always worried when we say, oh, it's great, we just create the dynamic and it works. I don't know if you practice gardening, but if you want tomatoes or if you want roses of a certain color, you know what you're planting. You decide and you design your garden to get what you want. So here's what we're doing too. We're designing this future. And what we heard today from the different colleagues and speakers, there is a design and there is a base. Often we're being pushed back because what we're saying or the reality that we're coming with is too complex. Huge needs, 6,000 rare disease. How do you do that? The world, you're too ambitious. Yes, exactly. That's the point. Is that we are able as a community to think complexity in a more simple way. We're able to simplify it into workable solution. And I loved what you said. In fact, it's not the goal that we want. It's an operational approach which fits for purpose. That's exactly what we're trying to design as much as possible in order to create the change we want really to see. Now, when I look back at the journey, I think we can be proud of something, is that we are not invisible anymore. There is not the same indifference as even a few years ago. You remember, first time we walked in this WHO office, these were our first words at 8 a.m. in the morning with Paloma, with you. And what we said was, if you're serious about leaving no one behind in your future agenda, you cannot leave out 200 million people and be indifferent, because that's what you're doing. So if you leave that door in 10 minutes, as you just announced, you're just trashing us in the bin, right? So what's the strategy here? So that has changed. And what has changed is because we have addressed the international community, which is embedded into the UN system. And yes, UN system is blah, blah. Yes, UN system is systems. But being at the root of the system, including the rare disease within the political declaration of UHC, it's a big step, which will have an impact over the next 20 years. Having the UN resolution is also huge. And having in the UN resolution the language, as it was shown on the slide just before, of bringing together expertise, of the needs of centers of expertise, on the need of global networking. These are words which are transforming the system and which are serving the people at the end. And our work is to work on the words to change the system. Where I heard WHA. So the UN resolution has much more than health. In the coming years, we will have already next year, in October, November, a second discussion of the UN resolution in the General Assembly of the UN. I don't know if you realize that when it was adopted, but it's coming already next year. We'll speak more about disability, more about social integration. We'll try to reinforce the text as we can. But health is here. And here we need to become much more operational. We need to get WHO to do more. So what we want to do as a next step, I don't know if we will succeed, but we can always try, is to have a WHO resolution by 2024. That's the goal. That then will build on what you heard today. We will build on the framework of description of rare diseases. We will build on the classification and codification with Anarat and the fantastic work that they did for the world with the other experts on that. We will build on some of the work of Lucia Monaco and Mary at that time and Garrett and others here in this room from the RDI, from the International Consortium of Rare Diseases, in order to have also with the 5 recommendations that Flaminia mentioned to strengthen the healthcare system. And you heard Rüdiger Krech saying it and Martin Seychelles saying it. So we need to come into their language, into their mindset also to transform the thing and to get all that into a WHO resolution. WHO resolution will not save more people than the UN resolution the night after that. Certainly not. But again, it will give another leverage to create the change we want to see locally. Then the local actors, you, the patients, the clinicians, the researchers, the healthcare managers can use that to transform locally their situation. The collaborative global network fits into that. So what we want now is to have more language, more reality about it, and we want it to become operational to disseminate the existing knowledge and to create new knowledge. So yes, it's all about the data. Martin said it, you all said it. It's a lot about the data. But the good thing is that now the European Commission is starting to say it's time to invest. It's time to invest, certainly. And I thank the opportunity to thank the ones who are already investing in our work to do it, which is extremely supportive. Where we want to go, it's a change of mindset. The change of mindset is to get the visibility of these people living with rare disease into the healthcare system and into society. This is what we can change with these next steps. And the recognition of people with rare diseases that they worth an early and reliable diagnosis. You were asking where you want to go in 2030? First thing, we want to diagnose rapidly, reliable. Believe it or not, it's only preliminary results, so we'll see in June, but we're doing a survey in Europe, already 10,000 replies. Has the world changed in Europe? Yes, it has in 15 years. Sufficiently? No. We still see years to get diagnostic. We still see an average which seems to be around 4 years. We still see more than 1 year before the first symptoms and a medical doctor. We see things that are not imaginable today. There is no reason. The technology is there, the knowledge is there, the people are there. It's just the system which is broken that we need to change, and the mindset. So we need to work on that. Also, the recognition that we're worth receiving quality care. And that's a change that we can create really internationally with this type of work. And that as human beings, we are worth this extra effort called equity. And it all goes back to that. Is that it's not just considering us like any other human. No, these humans are starting their lives with additional vulnerabilities and difficulties, and society has to help them to compensate for some of that in order to make their life and maybe reach some well-being. So the way we see our work is, in fact, really to create possibles. We open up possibles. We are not prescriptive about what we want to do completely. We're opening these possibles of new networking, but at the end, it will have to be the actors locally. And I conclude by saying that our strategy here developed with a future WHO resolution is not a strategy for low and middle income countries. We're not coming for a strategy to say RDI is about helping the poor. We never said it. So in case you think that we're doing that, no, that's not the goal. We're working for everybody. we think that our action is leveraging the situation in every regions of the world, in every country. Because in the US, we also have our issues of access to care. And in Europe, we do too. It depends where you live. It depends how much money you have in your pocket. It depends on your education. It depends on many things. Our strategy is also a strategy led by patient needs, but not for patients only. It's also for all stakeholders, for the clinicians, for the researchers, for the product developers, for the healthcare managers. So the togetherness is essential. That was mentioned all along. And all together, also, that we speak a lot because we are an RDI meeting and WHO context about RDI and WHO. But to succeed, it's all together. It's all together with IRDIRC, with Orphanet, maybe tomorrow with IFPMA, if they can get their act together as an industry at the global level. Maybe together with the Global Commission on Diagnostic, if they are able to restart a bit more. I'm the co-chair, but it's a bit slow. I'd like it to be a bit more dynamic. We need everyone. We need the Chan Zuckerberg Foundation with supporting. We need the bigger and other global foundations to get involved in order to move the agenda forward. And we also need the regulators at some point to work together, and I mentioned the major foundation of some in the industry. We need these different parts which are not yet activated. So we cannot be complacent, but we can be proud. I think we had a long day, productive day, and I propose to close by thanking you, Durhane, because you are really the incarnation of our fight. Thank you.